In today's video, we're going over surgery versus physical therapy for meniscus tears. What's going on, guys? This is Dan Pope and Kevin Coughlin. We are physical therapists, and we have gone through the literature on surgery versus physical therapy for meniscal tears, and we're here to share it today. How you doing, Kevin?
Doing well. I think this is going to be a great podcast. I think we're both advocates of surgery only and no physical therapy for meniscus tears.
I advocate for total meniscectomy. Just kidding.
Bilateral.
Bilateral. This is my favorite battle. I love going through surgery versus physical therapy articles. So this one should be a banger. Okay, so before we get rolling, I want to talk a little bit about the different surgical interventions. So we have the arthroscopic partial meniscectomy, we have arthroscopic meniscus repair, and we have meniscal transplant. And what I will say about the meniscal transplant is we don't have good research yet comparing physical therapy versus transplant with physical therapy afterwards. Although there's a pilot study, a protocol for a study, which hopefully will be completed soon, called Meniscal Transplant Surgery or Optimized Rehab, Full Randomized Controlled Trial, Meteor 2 study protocol. So we will get this information soon, hopefully, when this study is completed. But they are looking at it. So essentially, we're looking at physical therapy versus meniscectomy, physical therapy versus repair, and then we're going to be looking at physical therapy versus meniscus transplant. So kind of cool. We'd love to get that information because if you have a patient coming through the door, we have to have the right plan of care, right? It's like, hey, do we send back to the surgeon to get a surgical consult right away? Do we start physical therapy? Kind of have to know these things, right? Right off the bat, going to hit you with some profound statements. And this is from BJSM 2017 Clinical Practice Guidelines, arthroscopic surgery for degenerative meniscus tears. So keep in mind, this isn't degenerative meniscus tears. If you guys need to know the difference between, let's say, an acute tear and a degenerative tear, then go back to our first episode on the meniscus where we discussed this. But they strongly recommend against arthroscopy in nearly all patients with degenerative knee disease, right? This is folks have degenerative meniscus tears with or without accompanying arthritis. This is patients with or without mechanical symptoms or sudden symptom onset. And it's a little bit challenging to decipher between acute/degenerative. Sometimes if someone has a really sudden onset, it could actually be a degenerative tear, right? So hard to know. But they draw a hard line in the sand. Hey, yo, I've got something for you. It is an evidence-based cheat sheet on meniscus pathology. And I get it. Stay on top of literature for all the pathologies that are coming out. Very tough as a physical therapist. Well, I'm going to try to simplify it for you. I've taken all the relevant information about the meniscus and jammed it all together into a cheat sheet. And my promise to you is I'm going to catch you up to date on meniscus pathology in under 10 minutes. In the cheat sheet, we go over mechanisms of injury, prevalence, acute injuries versus chronic injuries, anatomy of the meniscus, examination, types of meniscus tears, surgery versus physical therapy, and some rehabilitation principles for you. So I'll leave a link in the show notes in the description below. This is 100% free. Go ahead and click on that link, download it, and get learning. Now back to your video. What do you think, Kevin? Do you agree with BJSM? Or are you going to say the opposite?
Yeah, it is interesting. I guess the question that pops in my head is with mechanical symptoms, like someone's trying to be active in the gym and do, squats and lunges and stuff like that, and they're getting a clicking in their knee, or it feels like their knee's locking. I'm interested as to the rationale of why they wouldn't want to do a meniscectomy with that person, perhaps. But yeah, interesting stuff. What do you think with that?
Well, to be continued, right?
Oh,
I'll give you a
on the edge
little
of my seat.
tidbit. It depends on if the person had a degenerative tear or if they had an acute traumatic tear. We'll say that. There's a recent article that basically goes into that. Just to give you a quick bit of information for degenerative tears, if you do physical therapy versus have surgery, it kind of resolves at the same rate, which is interesting. So those mechanical symptoms, and at least in the study I'm talking about, I'll go over that study more in depth. But they basically found that over the course of time, mechanical symptoms tended to go down, although those mechanical symptoms were kind of poorly defined, right? Locking versus catching, objectively locked, so on and so forth. So largely what this clinical practice guideline is saying, though, I'm trying not to get too off track, is that they don't want you to get a meniscectomy if you have a degenerative meniscus tear. We have a lot of research to show that, and more research at this point is probably not going to change the prior research. We're pretty certain that you probably don't want to get a meniscectomy if you, at all you can not get one, right?
Mm-hmm.
So for degenerative meniscus tears, arthroscopy was no better than exercise therapy. And randomized control studies have shown that arthroscopic partial meniscectomy and physical therapy after meniscus tears result in significant functional improvement and decreased pain compared to baseline. However, no randomized trial effectively supports the notion that meniscectomy is superior to non-surgical management of degenerative meniscal tears. And on top of that, meniscectomies lead to longer-term osteoarthritis. So what they're saying here is that you're not going to find research that shows that partial meniscectomy beats out physical therapy. And you'll find some studies, like I said, I already alluded to this, is that in the short term for degenerative tears specifically, physical therapy can outperform meniscectomies. That's going to be very different from patient to patient. So again, if you're watching this and you're a patient, just got a meniscectomy, you're probably freaked out. You're like, why did my doctor prescribe this? Like, there are reasons for that, right? But yeah, if at all we can do physical therapy and get better, we still want to try this. We spoke about this in previous podcasts. Meniscectomy is still a very common surgery. You see it quite a bit. So I think as physical therapists, we're trying to protect our patients. And like, surgeons aren't nefarious and trying to destroy everyone's knees. They're not. They're really not trying to do this. And there are good candidates for meniscectomy. But we just have to be cautious with those patients that maybe don't give enough time, maybe didn't rehab well enough, go back to the doctor, end up getting a meniscectomy, and then they get another meniscectomy, and all of a sudden they're looking at a different surgical procedure down the line, have a lot of knee arthritis. That's something we want to avoid if at all possible. Any thoughts there, Kevin?
Yeah, no, that makes sense. So perhaps these folks with the degenerative meniscus tear do better with physical therapy, and they don't necessarily need the meniscectomy. And we know that it could increase their risk of developing worsening arthritis in the future.
Mm-hmm.
I guess if you have a patient coming in and you're suspecting a degenerative meniscus tear, would you send them to a surgeon to get baseline imaging before doing your bout of maybe 3 months of PT? Or are you going to try that PT first? And then if they're not doing well, refer them to the surgeon? Which comes first in your mind, or does it matter?
Yeah, I think there's always that potential that this patient has something that could be repaired, right?
Mm-hmm.
But if you're giving it 3 months and you send back to the doctor, if it was something that could be repaired, probably still can be,
Mm-hmm.
right? So I do think from a critical reasoning perspective, you probably can start physical therapy right away. And really, if they're making no progress, then you can send them back to the surgeon, or send them to the surgeon if they're kind of direct access. But I see no harm in at least trying to treat them first, as long as you're not telling them to do something that's absolutely crazy. It's going to ruin their knees, right? So here's a study. We talked about how important it is to try physical therapy first. Here's a study to help illuminate this. And this was the Meniscal Repair and Osteoarthritis Research, the METEOR study. It's a large multi-center randomized controlled trial. They're looking at 351 patients, less than 45 years old, with degenerative meniscal tears and mild to moderate osteoarthritis. Group 1 had the partial meniscectomy plus physical therapy, and Group 2 had physical therapy alone. Now, what I will say is that I bet you if the meniscectomy group didn't have that postoperative physical therapy, they may even be in a worse spot, but that's just my bias. I don't actually know if that's true. What outcome measures are they looking at? Western Ontario and McMaster University's Osteoarthritis Index, the good old WOMAC physical function score. And they were looking at 6 months outcomes. And at the 6-month outcome, partial meniscectomy WOMAC scores improved 20.9 points compared with 18.5 points improvement in the conservative treatment group. And there was a non-significant difference between groups, meaning that didn't matter if you got surgery plus physical therapy versus physical therapy alone. And at 12 months, there were non-significant differences between groups as well. So, makes sense. Probably want to try physical therapy first because it works just about as good. And here's another important point. 30% of physical therapy patients cross over to the partial meniscectomy group in the first 6 months. And after they've crossed over to the partial meniscectomy group, because they weren't doing well, they end up doing just about as well as the folks that got the partial meniscectomy, right? And there was no problem delaying it. So to your earlier point, can we just have these patients try some physical therapy? And if it's not working, we can send them to the doctor. Yeah, we can do that for sure. But if you are suspecting a degenerative tear, there's a good chance that they're only going to be able to perform a meniscectomy anyway, right? So these folks in this study said there's no disadvantage by prolonged conservative management before undergoing arthroscopic partial meniscectomy. And then the other thing that I wanted to note on is that there's a 30% crossover, right? So here I am saying, like, you got to try physical therapy first. But keep in mind, 1/3 of these patients almost decided to get surgery because they weren't doing well. So, yes, we want to try physical therapy first, but 30% of those folks might not do well, and they may need that partial meniscectomy. So, it's really unfair to say that physical therapy works for everybody because studies like this are actually showing that 1/3 of patients end up getting surgery because they're not happy with physical therapy. Any thoughts on that, Kevin?
Yeah, that's interesting, and I think it's good to see that. I think this is one where we could say it's relatively comparable and it's worth trying PT first in terms of the long-term outcome. I guess a question I have for you, I have a patient who I have right now who has a non-op meniscus tear. Uh, Clinically presenting with a meniscus tear, from my perspective and her orthopedics perspective, but she has not had an MRI to confirm that yet. Anyway, she's very fear avoidant about doing certain things during the rehab process because she's fearful that squatting or other lower body strength training exercises are going to make her meniscus tear worse. Are there any exercises in this conservative treatment that you would stay away from on principle, whether that's strength training or plyometrics or running? Or do you let symptoms kind of dictate what to do?
Yeah, I think we'll probably cover this more in depth in some of the rehab videos, and I can kind of delve into these studies a bit more to give some of the listeners or the viewers a little bit more idea of what these studies actually contain from an exercise perspective. Long story short, I just basically give people exercises based on their symptoms, right?
Mm-hmm.
Kind of a patient monitoring model. I think one of the bigger differences between, let's say, a tendinopathy and joint-related pain is that we have to respect things like range of motion as well as swelling. Whereas you don't see as much of that in tendinopathies. And I will also say, and this is anecdotal, but I tend to probably push through a little less pain for meniscus patients than for, let's say, a tendinopathy. So I'm just a little bit more conservative for these folks. But yeah, I basically exercise them with tolerance. Is that what your thoughts are, Kevin?
Totally. Yeah. And that's what that's what I explained to this lady. She's still fear avoidant and concerned that there are certain exercises that even without symptoms are making her meniscus worse. But I think the best we can do there is educate and try to promote activity that the person wants to do. I guess at the end of the day, I'm not going to make them do anything they really don't want to do. But I think we can let symptoms guide us. And I usually tell them, about the pain monitoring model, I lower the number a little bit. Like you, I'm more maybe in that 0 to 1 or 2 at most range, but that's with the caveat that swelling and range of motion don't change in like a 24-hour period. We kind of want to make sure that we're not seeing worsening outcomes from those two standpoints, because to me, maybe that means that the tear could be worsening a little bit versus if they just have quad soreness but no knee joint pain. I feel like what we're doing is probably the right thing.
Yeah, I wonder if we'll figure that in time.
Yeah,
What's acceptable from a pain perspective with joint related pain versus like tendon related pain, right?
right.
Kind of interesting. All right. So this was a doozy of a study, one of my favorites, the Finnish Degenerative Meniscal Lesion Study, also known as the Fidelity Trial. And this was a double-blinded, sham-controlled trial, which sham means fake surgery, which when this first came out, I thought this was a great study. Just made me smile. So they had 146 patients, 35 to 65 years old. They had non-traumatic degenerative meniscal tears and no evidence of osteoarthritis. And they also got physical therapy afterwards. The outcome measures they use, the Lysholm Knee Scoring Scale, LKSS, Western Ontario Meniscal Evaluation Tool, the WOMET. And essentially, they had one group that got an actual meniscectomy, and then they had physical therapy afterwards. And the other group had a sham meniscectomy. So a person went under, thought they were getting meniscus surgery. They didn't. They just closed them back up again and then gave them physical therapy afterwards, right? And essentially, the mean improvement at 12 months, the LKSS score, was 21.7 points in the partial meniscectomy group versus 23.3 points in the sham surgery group. Pretty wild. So looks like the sham actually outperformed. Not by much. I don't think it was a clinically significant, but I just think that's hilarious. In the WOMET score, there's a 24.6 improvement in partial meniscectomy group versus 27.1 in the sham surgery group. And again, sham's winning. There's no significant difference in improvements in patients undergoing partial meniscectomy compared to sham surgery. So at the end of the day, the differences were non-significant, although I just think it's hilarious. They got a sham surgery and they did slightly better than actually getting the real surgery. So studies like this just kind of go to show you that it's probably a good idea to try physical therapy first, because obviously when you do the meniscectomy itself, it doesn't seem to change outcomes. Were you familiar with this study before, Kevin? I know this kind of floated around for a while.
Yeah, no, I'm not. But, there are studies of different types of sham surgeries. And I think this is the type of study you can see just like running wild on social media, where kind of saying that it doesn't matter if you get you don't need a meniscus surgery, clearly. But I think to your point, what it should show is that we should try physical therapy first, and some folks will do well. Or instead of not doing meniscectomies, we should do sham meniscectomies on people.
Yeah.
That does the best.
Just go sham from the get-go. Yeah.
Sham from the get-go.
That'd be funny if surgeons were telling their patients that. Be like, we're going to do a surgical procedure. It's called a sham meniscectomy. Essentially, we're going to open you up and then close you up, but tell you got a meniscectomy.
Yeah.
And that works the best.
Pretty good.
Hilarious. All right. So we already noted about this a little bit, but talking about crossover rates. So essentially in these studies where they're offering physical therapy or they're offering surgery, if a patient wasn't doing well, then they would offer them the meniscectomy, right? So essentially going from that conservative group over to that surgical group. And it can be as high as 21 to 30%, somewhere between 6 and 14 months, depending on the study that you're looking at, right? And then patients that cross over to the meniscectomy group from the conservative group end up having similar outcomes compared to the meniscectomy group, right? So I don't know, it's 1 in 3, 1 in 5 folks who trial conservative care don't do well, and they want to get the meniscectomy. And the partial meniscectomy remains an option after failed conservative management. And to your earlier point, this would be a time period where you can refer patients out. They're not getting better. Usually around 3 months is the time frame based on those ESCA guidelines, but you could make an argument for a little bit longer and see if they're progressing. And if they're not, maybe refer them out, right? I think we had spoken about this before, but if you wait 6 months and your patient's not doing well with physical therapy, and then you send them to get surgery, now you're looking at a much longer period of time until they feel good. So 6 months of waiting, followed by, let's say, another 3 months of surgery, followed by physical therapy, that's a long period of time to wait. So I think that the argument you can make is you may delay recovery in some folks by trialing physical therapy first, but you're saving people time on the back end, potentially, if they're having worse knee symptoms because they might be developing osteoarthritis as a result of the meniscectomy. So probably worthwhile, but again, you do potentially waste some time for certain patients. Any thoughts there, Kevin?
No, yeah, that's all good.
Yeah. All right, we'll move it on then. So another study, this was in traumatic tears. So up until this point, we're talking about all degenerative tears. What about those acute traumatic tears? You have a patient who's playing soccer, they twist, they feel a pop in their knee, a bunch of swelling, they come in, You say, hey, I think you have a meniscus tear. They go to the doctor, they get some imaging, and yup, they have a traumatic meniscus tear. Do these behave differently than degenerative tears? Should we do more surgery? What do we do? This study was entitled Arthroscopic Partial Meniscectomy versus Physical Therapy for Traumatic Meniscal Tears in a Young Study Population, randomized controlled trial. So keep in mind, when you have a younger individual has an acute tear, you're going to try meniscus repair. But the majority of those folks are not going to be able to get a meniscus repair. So their options are, should we do physical therapy or should we do a meniscectomy? And that's what this study was looking at. They're looking at 100 different patients. The majority of them, 73%, were male, and 1/3 of those were competitive or elite level athletes. The average age was 35. So it's not like you're a bunch of like teenagers playing sports. You have a mix, and they're upwards. Some are a little bit older, so that mean is a little bit higher. They're still relatively young. And the results showed that early arthroscopic partial meniscectomy was not superior to a strategy of physical therapy with optional delayed arthroscopic partial meniscectomy at 24-month follow-up. So in patients, they have a meniscal tear, they go into the doctor, and the doctor says, we can't perform a repair on you based on the type of tear that you have. And you can start with physical therapy. And it kind of looks like, at least a 2-year follow-up, they do about as well as getting the partial meniscectomy. So just like the degenerative tears, we could probably start treating them conservatively, and chances are they're going to get better at the same rate as doing the partial meniscectomy. Any thoughts there, Kevin?
Yeah, no, that's interesting too. So yeah, after an acute tear, would you, if this was you, would you try physical therapy first before you got a meniscectomy for this?
Yeah, I'm an odd guy though, right? Like sometimes what I do is not what I recommend my patients do, but we'll talk about this in a second. But if I tore my meniscus, I probably wouldn't want to know if it could be repaired. And if it could be repaired, probably want to do it, right? But we don't have long-term data to look at patients that were potentially good candidates for repair, getting surgery versus not. Because if I have a tear in like a red zone, will that spontaneously heal? Maybe. And will my long-term outcome be about the same as getting a meniscus repair? Maybe. We don't know that. What's interesting to me, and this is kind of like a historical thing with surgery, it's kind of like you see the same with like hip preservation surgery, is the thought process is, if I can repair the labrum, that will extend the lifespan of my hip, right? Thought process in the meniscus is that if I repair that meniscus, probably can extend the health span or lifespan of my knee joint as well, right? But the majority of meniscus tears that get repaired occur in an area that already heals pretty well, right? So we know that some of these spontaneously heal. We just don't have good data that compares the non-surgical approach versus the surgical approach, right? I would love to see that data. We don't have that yet, right? But I would potentially like to be that person that has a tear in that red zone that trials conservative care, right? And maybe that heals. Maybe I have a pretty good long-term outcome. Who knows, right? Good question. Don't have the answers, but there's a study in a minute that kind of hints towards an answer. We'll say that. Okay. So this is that exact study that I was mentioning. And this was pretty cool. It was called Early Surgery versus Exercise Therapy and Patient Education for Traumatic and Non-Traumatic Meniscal Tears in Young Adults, an exploratory analysis from the DREAM trial. What's kind of cool is that I didn't have access to this study, unfortunately. I tried my best to get it a couple of years ago when I did a lit review recently, and I was actually able to get access now because they actually republished a lot of these results in JOSPT and used the data to like publish other trials, and I was able to access all of that via JOSPT. So this was a 2022 study, but this was republished in 2024 where they're looking at additional things like mechanical symptoms. And essentially, they're looking at early surgery versus exercise and education. The exercise and education group was given exercise and education over the course of 12 weeks. And what was kind of neat and different from the last study is they were looking at meniscectomy or repair, right? And one of the things I didn't have access to in the last time I did a literature review was how many of these patients got a repair versus how many of these patients got the meniscectomy, right? Because I would love to know how folks do after meniscectomy after repair versus just standard physical therapy. Because traditionally the advice has always been, hey, if we can repair this, let's repair it. It's almost like doing a disservice to a patient if they can't get a repair, or if they can get a repair, to tell them to do physical therapy is somehow harming them. But this study was looking at actually letting those folks do physical therapy. The big problem here was that only 5 out of 47 patients with traumatic tears had a repair in the surgical group. So a large majority of the patients in this study were meniscectomies and not really repairs. So this was a little bit sad. And maybe someone can crunch the data on this at some point in the future. But I would love to see if they were looking at just repairs, if the outcomes would be different, right? And only I think 75% of the patients in the study had traumatic tears. So some of these patients actually had degenerative tears or chronic tears, right? And only 5 out of 47 patients that had traumatic tears had a repair, and 5 more of those patients had a partial repair with a meniscectomy. So again, the percentage of patients that actually had the repair was kind of low, which goes to show you that most patients can't get a repair. Most patients only really have the option to get the meniscectomy, unfortunately. And these patients also had the option to have surgery later on. There's 121 total patients aged 18 to 40. So only 10 of those patients actually ended up having a repair. You can see that's a very low percentage of all the population. Again, only 75% of those were traumatic. And at the 12-month mark, there was no difference in pain, function, or quality of life. Okay. Now, a few thoughts here. So if I have a patient that could get a meniscus repair but doesn't, gets physical therapy, seems like they're going to have the same outcome at 12 months. What the hell is going to happen at 10 years, 15 years, 20 years? And I kind of looked to see if they had published more data on what was going on a little bit later on, and they don't have that out yet. So this study started in 2022, I believe, right? Or was published in 2022, and they had the 1-year results at that point. I was kind of hoping they had some 3-year results, but maybe they will follow up these patients in the DREAM trial in the next 5, 10, 15 years, kind of like the Moose Mare patients after rotator cuff repair. But time will tell, right? Because we do have that data about ACL reconstruction patients having more osteoarthritis than non-ACL reconstruction patients. So it's like these patients that we think we need to repair the meniscus, will we find over the course of time that if we just leave them alone, they do better? Who knows? But at least this study is starting to try to answer that. And I would just love to see what happens in the next 10 years, right? Hopefully they do kind of publish that data because who knows? Maybe more conservative care is actually better for folks that could get a meniscus repair too. But I'm not sure, right? Any thoughts on that, Kevin?
Yeah, I think it's an interesting study that kind of gets the ball rolling to look at those things long term. I guess there is just a lot of heterogeneity in that study, right? Like 18 to 40 is a pretty big age range. And then it's also looking at traumatic versus non-traumatic, right? So, there's a few things to consider there when applying it to your patient, but definitely a good study trying to get more information.
Yeah, I know that on social media when this study was published, a lot of folks were saying like, you don't need surgery, right? Here's a study looking at meniscus repair and meniscectomy versus physical therapy. Physical therapy group outperformed or did just as well, right? A, we don't have those long-term outcomes, and B, it wasn't as exciting as we kind of want it to be, just because they combined too many things together, right?
Mhm.
And I don't know, and I'm not a statistician, but I don't know if there's enough patients to have a high-powered trial to take those 10 people and see if there's actually a difference, right? I don't know enough about statistics. Maybe we'll get those authors on the podcast at some point to discuss that. But yeah, it's a little tough to hang your hat on that study and say like, yeah, if you have acute meniscus tear and that could be, let's say, repaired and you just do physical therapy instead, right? Or maybe don't get imaging and don't know what's going on in your knee, you're going to do just as well. We can't say that based on this study. We need more studies like this. But I thought this was really interesting and kind of cool to start seeing the beginnings of us figuring this out, right?
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sportive fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the fitness pain-free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. Okay, here's another one, Kevin. And this, I wish there was more research in this. It seems like we would have a ton of research on this, but we don't. Do meniscal tears heal on their own? What do you think, Kevin? Do they heal on their own?
Never. I would say never.
Never. Okay, well, let's see. So this was a cool study. It was called Healing Potential of Meniscal Tears Without Repair in Knees with Anterior Cruciate Ligament Reconstruction. I believe the study is in 2004, AJSM. It's a little bit of an older study. And this was pretty cool because it blows my mind that we don't have answers to questions like this, despite having so much research about certain surgeries, so on and so forth. It's like, does a meniscus tear heal after you have an injury, right? Because if it doesn't heal, then we would consider surgery. But if we know it's going to heal, then why the heck do we start with surgery? It doesn't make a lot of sense to me. So this, unfortunately, was in patients that were undergoing ACL reconstruction, right? So these folks had traumatic tears. And the thing about the traumatic tears is that they were also stable. And we know that stable tears usually do a bit better than unstable tears. So basically, there are a lot of variables that weren't controlled for in this study that we would have to know. What kind of tear was it? Where was that tear? Anterior, posterior, medial versus lateral, red versus white, right? There's a lot of questions that we have here because all of those things are probably going to influence healing rate. We just don't have the research to show this at this point. But at least the results from this study were pretty shocking to me. I'm going to just go ahead and read these to you. In 41 medial torn menisci left without repair, 56% of those were considered completely healed, 7% were incompletely healed, and 24% were unhealed, and 10% had expanded unhealed lesions. And this is amazing to me because literally 56% of these ended up healing. And we know that after you have an ACL injury and after you have ACL reconstruction, that's going to increase the likelihood of having a spontaneous heal. But 56% of these healed on their own. That's crazy. In 42 lateral torn menisci, 74% were considered completely healed, 5% were incompletely healed, 14% were unhealed, and 7% had expanded unhealed lesions. So essentially, 3 out of 4 on the lateral meniscus, probably because the lateral meniscus has better blood supply, were considered completely healed after ACL reconstruction. And this was at second look arthroscopy, 17 months after the ACL reconstruction. And this blows my freaking mind because they're showing somewhere between 50% and 75% of these meniscuses will heal on their own. And it's not fair to just assume that 50 to 75% of all meniscus tears will heal. That's not true whatsoever. There's a lot of reasons why these potentially healed better than other forms of meniscus tears. But at least in my mind, my first thought is like, why don't we have better data of which parts of the meniscus heal well? And why aren't we allowing some of this spontaneous healing to potentially occur? And if it's not occurring, then we perform surgery. And essentially, I couldn't find a lot of additional research that gave specific numbers, but several studies kind of hints at the notion that meniscus tears in the periphery can spontaneously heal, right? But again, I couldn't find any specific rates. What are your thoughts, Kevin? Because when I first read this study, I was like, whoa, you know?
Yeah, it is very interesting. I think, more research probably has to be done, like you said, to figure out which of these tears are healing on their own, like what location in the meniscus, what type of meniscus tear, because we know if left untreated, a lateral meniscus tear, it's so important for distributing stress in the knee. It can get worse and it can lead to arthritis, but I think there's a lot of nuance to this that we don't yet know. So, in one hand, we see not repairing it, it could potentially lead to worsening stress in the knee long term, worse knee health long term. But then on the other hand, we see that studies like this showing that a lot of these tears, in the lateral meniscus, in this one, 3/4 spontaneously heal without surgery. So, there's a lot that we need to pay attention to in the research in the future as more and more comes out on this kind of stuff. But, if it gets to the point where with good imaging techniques, we know that like this particular meniscus tear has a really good chance of healing on its own, maybe we do a follow-up image to make sure that it is healed, versus this other type of meniscus tear does not heal well on its own. And this is the one we have to repair, or do a meniscectomy on. Yeah, there's a lot, it's exciting. I think there'll be a lot of good information coming out in the coming years. But the fact that that's an option and it can happen sometimes, I think is really cool. And like you said, maybe this is a different scenario in an ACL reconstructed knee. Like there are a lot of factors at play that lead to healing in this type of person. But, pretty interesting stuff. And I never would have thought it would be that high. That was way higher than I would have expected.
Yeah. And kind of my fear too is that it's not going to get solved soon, Unfortunately, that happens a lot in research. You see like a little bit of research on a certain subject, and then, the area gets less popular. People don't do research on it. 20 years later, we haven't made any progress. So, that study was in 2004, I want to say, and I haven't seen anything subsequently. So my fear is that we won't get that information anytime soon. But to your point, it'd be really nice to get more data like this heals, this doesn't. I'm actually a little bit surprised because I know that, in certain countries like the UK, you have to wait a large period of time until you get like ACL reconstruction. And then we end up getting a decent amount of data from those types of places just because these folks will end up with an injury. And then basically we see if they heal over the course of time because they don't have the option to get the surgery. Whereas in the States, like you get the injury, like, you get surgery right away. So I'm kind of surprised we don't have that data. Maybe we do somewhere. I would say that if you're listening to this and you have more knowledge on this, you've read some studies or you do the research on this, I would love to hear it, because I'd love to learn more,
Yeah, not to be a conspiracy theorist, but you wonder if part of the reason, well, one is this particular information just might not be disseminated well, but also, surgeons and stuff like that, maybe they assume that we know it does fairly well when we repair it if we can. And, that's a moneymaker, I guess. I don't want to think of it that way, but potentially a reason that maybe it's not studied as much as it could be. But yeah, just something popped in my head. Not a big conspiracy theory guy.
I know. I know what you're saying. It reminds me of like acute rotator cuff tears. Like you'll see all over the literature, if you have an acute rotator cuff tear, we repair it. Why? Because we know they do well. It's like, all right, well, do they do well without surgery? Because you probably got to figure that out first, you know?
Mm-hmm.
Like I know, again, conspiracy theorist, but I have like a part, like let's say I have a full thickness tear, but it's not like a very big one. If I let that go versus having surgery, does that do well? Yeah, very well. You know what I mean? I just, sometimes it's like we skip a step. It's like,
Yeah.
oh, hip labral repairs because we're preserving the long-term health of the hip. It's like, do you know it preserves long-term health of your hip? No, but we assume it does, right?
Yeah.
And you kind of have to do the surgeries to get the data, right? Because we have to wait after the surgery to see. But to your point, it's another one of these like time will tell, and do we skip steps kind of thing before? I mean, I would much rather have the option of getting my hip labrum repaired as opposed to they just invented the procedure, they do a study, they wait 20 years, and then they decide, right? So, and just kind of an interesting thought experiment. Like I still recommend my patients get like a meniscal repair, right? If they can get it repaired. I'm not saying to just go willy-nilly and go Wild West and try to figure it out yourself, but I would love to hear more about that and learn about it. Yeah. All right, Kevin, another big question. What about mechanical symptoms? So we already alluded to this a little bit. We'll first talk about degenerative tears. So essentially, if your patient experiencing something like locking, catching, could be the meniscus is stuck in the joint. And the thought is like, you got to have to get rid of that meniscus to reduce these mechanical symptoms, right? So in the Fidelity trial, they were looking at physical therapy plus surgery. And they're also looking at physical therapy plus sham surgery, right? And here's what they found. Mechanical symptoms resolved over time at a very similar rate, which is very interesting, kind of meaning that maybe that meniscus is not necessarily causing those mechanical symptoms. And maybe something about physical therapy helps reduce mechanical symptoms. And I'll also say, this is very anecdotal, but when patients come in, they're like, oh man, my joint's cracking, popping like crazy after they have an injury. Sometimes I think it's because it probably cracked and popped a lot beforehand. And essentially the patient has pain there, and now they're just have a heightened awareness. So they're noticing that cracking or popping. But the other piece is that oftentimes a lot of that cracking and popping goes away. And maybe this is what's going on with physical therapy. Maybe physical therapy actually reduces some of those mechanical symptoms over the course of time just by using that joint. I don't really know, right? But at least in this study, they showed that fake surgery reduces mechanical symptoms as well as a real surgery. And I remember, I want to say in that study, they actually showed that mechanical symptoms kind of just slowly got better over the course of time, meaning that in the surgical group, the meniscectomy, it's not like the mechanical symptoms went right away. They slowly went away over the course of time, which doesn't make any sense. If you're removing the meniscus that's causing the mechanical symptoms, it should go away right away. That's not what that study showed. So interesting. So they showed a non-significant difference in mechanical symptoms between groups. Again, this was degenerative tear, so important to keep that in mind. And then the ESCA guidelines for meniscus surgery showed grade D evidence that surgery can be proposed earlier for patients presenting with considerable mechanical symptoms, right? But largely the study is not supporting that. So if you have a patient that has mechanical symptoms from a degenerative tear, I wouldn't say, go ahead and get surgery. It's going to fix it, because it seems like, at least based on this trial, exercise might fix it too, right? And I think the other piece, we already covered this, but in the Fidelity trial, they didn't really define what mechanical symptoms were very well. So what if you have an objectively locked knee? Does that need to have surgery? I would think so, right? But I don't think that we've parsed that out completely. Any thoughts on that, Kevin?
Yeah, that's interesting. And something I would have thought previously is having mechanical symptoms is a more severe type of meniscus tear and something that we need to get surgery on quickly because it's going to fix it. So that's great information. I think there are like two ways that PTs think about meniscus tears and mechanical symptoms. I think one is what I just said, like you need surgery to fix that, or with some of this newer evidence showing that it gets better with physical therapy alone, you don't need surgery at all and it's going to go away. But I think that middle road kind of nuanced approach is maybe physical therapy can get rid of it. Let's do some PT and wait and see. We don't necessarily have to rush into this surgery. But it's good to let the patient know, like, let's track this over time and see if these mechanical symptoms are improving. And then I think we know we might be heading down the right path.
Yeah, good point. Yeah, for sure. So you can help with their reasoning for patients and let them know that there is potentially some hope there. All right. So, Kevin, what about mechanical symptoms after a traumatic tear? We know that after someone has a degenerative tear, doesn't seem to matter if we get surgery or not. Those mechanical symptoms go away over the course of time. Does that hold up with traumatic tears? So usually these are young athletic folks that feel a pop in their knee and they end up having an acute tear, right? So different type of meniscal tear. And this information is coming from the DREAM trial. So that same study that we were mentioning previously, where 75% of those tears were traumatic in nature. And this was a little bit different in terms of outcomes compared to the last study mentioned for degenerative tears. So in this study, in the DREAM trial, at all time points, the exercise group reported more mechanical symptoms compared to the partial meniscectomy or repair, right? So this would mean that if you have a traumatic tear, chances are those mechanical symptoms are not going to go away over the course of time. And they actually showed a graph in this study where they're looking at mechanical symptoms. And what they showed is that in the physical therapy group, they kind of stayed the same over the course of time, meaning that they really didn't change. And in the surgical group, the mechanical symptoms went down right away after the surgery. And I want to say at the 1 year mark, they went up a little bit, which kind of makes sense. So if you're starting to get some of these meniscus repairs and tears potentially being revised, or excuse me, not being revised, but re-tearing, then maybe now we're getting some more mechanical symptoms a little bit later on. So largely, if you have a traumatic tear, those mechanical symptoms seem to stick around despite doing physical therapy. And what this study kind of said that is if your patient is particularly affected by mechanical symptoms, then potentially consider surgery. But do keep in mind with the DREAM trial, pain and function still improved the same rate with surgery versus conservative care, but mechanical symptoms didn't. And if the patient is cool with their mechanical symptoms, they obviously don't need surgery. But if mechanical symptoms is like a really big pain in the butt, they really want to get rid of them, then maybe they would consider surgery at that point. Any thoughts with that, Kevin?
Okay, gotcha. So that previous slide was more about the degenerative tears. Okay, yeah. So I think the theme still is consistent a little bit, right? So it does seem like the traumatic tears, which occur more often in younger folks, potentially more involvement in the lateral meniscus, which we know is really important for distributing stress. Maybe that theme, they have mechanical symptoms. They might be, or they might do a little bit better with surgery, and it can help abolish some of those mechanical symptoms. So, but still something we could try in PT. And if it's not getting better and it's important to the patient, could opt for surgery.
Yeah, it's kind of one of my thoughts too. If the person had a traumatic tear and they're trialing conservative physical therapy and they're having mechanical symptoms, I can't say like, look, there's a good chance it goes away. The research we do have, and it's just one study, right? Maybe future studies will change this. It's just kind of showing that they tend to stick around, right? So if there's a big concern of yours and over the course of time it's not improving at all, then we can consider something like a meniscectomy, but there's risks that come with that. So essentially, patient education standpoint, we got to let them know, like if you get a partial meniscectomy, it may reduce some of those mechanical symptoms. But the flip side is that it probably increased the rates of osteoarthritis over the course of time too. So it's a double-edged sword there, right? But unfortunately for those traumatic tears, like you said, unlike the degenerative tears, that they don't have reduction mechanical symptoms over the course of time with exercise, unfortunately.
A question I get a lot from patients is like, do you think the mechanical symptoms they're experiencing are an indication that the tear is worsening?
It's a good question. I guess I don't know. I'm not really sure. I would think not, just because my main thought would be it takes a lot of force to tear that meniscus. And
Yeah.
if you're doing basic PT stuff and just moving around the house, I don't think it would tear it further, but I could be completely wrong there. I'm not really sure.
Yeah, I usually tell them just monitor if usually kind of a rule of thumb I use is if the clicking or popping or mechanical symptoms are associated with quite a bit of pain, and with that you see an increase in swelling, maybe it's something we got to be really careful of. But otherwise, it does seem sometimes to get better on its own. I know with this acute traumatic tear, it might be a little bit different, but yeah, I tend to say we don't know, but I don't think it's associated with worsening structure of the meniscus unless it's accompanied by a bunch of pain.
Let's go over some clinical reasoning, excuse me, not Riesling. That's what I drank last night. Just kidding. Some practical takeaways. So what are some factors favoring success with conservative treatment? So a patient comes in, you think they have a meniscal tear, but they can bear weight, they have minimal swelling, have a delayed onset of symptoms after injury, so no concomitant ligamentous damage, they're minimally restricted in terms of range of motion, then we can consider doing physical therapy. And I think the other thing, just keep in mind that meniscus preservation surgery improves long-term health of the joint and shouldn't be seen as a bad option. So let's say you have a patient that comes in, they have a meniscal tear, but they seem like they're going to be a good candidate for conservative treatment. Still might be the best thing to send them back in for some imaging, because when repaired, we know the meniscus does well, and it's probably important for the long-term health of the joint. So if a patient doesn't seem like a good candidate for conservative care, on the flip side, probably still should try physical therapy because it may make a really good turnaround, right? We have research to show that. What are some good candidates for surgery in folks that have had a traumatic tear or an acute tear? So the first line treatment for these folks should be repair or non-removal. Now, why would you consider non-removal? These are usually good rehab candidates, and they typically have success with rehab, return to function, return to sport. If not, surgery can then be considered. Which surgery? Repair as often as possible. So meniscus repair is going to be the gold standard if possible to prevent secondary arthritis. Keep in mind, you can't always repair. The majority of your patients with meniscus pathology are not going to be able to be repaired, unfortunately. And then you consider a salvage procedure in the case of a prior meniscectomy where the patient had a lot of their meniscus removed. They may be a good candidate for the meniscus transplant. Do keep in mind that timing influences your outcomes. So acutely repaired meniscus tears achieve superior results versus chronic generally. So it's good reason to see the doctor sooner than later. Although keep in mind, we just looked at the DREAM trial where patients tend to do well with surgery later on. And in that surgery, they were also looking at meniscus repair later on, not just meniscectomies. Chronic meniscus tears can also achieve good to excellent results and should be repaired when indicated. And age doesn't seem to matter. So you have a patient that has had a chronic meniscus tear that's been going on for a few years, and you send them in to go see the doctor, and it's something they can actually repair, then go for it. Just because it's been going on for a longer period of time doesn't mean it's not a meniscal tear that can be repaired. I had a patient of mine, it was a couple years ago at this point, who came in and had a meniscal tear that could have been repaired, but he wanted to get back as soon as possible. And we rehabbed this conservatively. He did really well. And then a year and a half later, he got it repaired and did really well again. But the thing about this patient is that he actually started to slide backwards after a period of time too. And he was trying to get into the fire academy, and he just needed to be able to pass a bunch of tests, right? And if he got the meniscal repair right away, he wouldn't be able to actually get the career he wanted to. So he ended up delaying it, right? And he was able to get the repair later on. So just because it's been going on for a while doesn't always mean it's a degenerative tear. It's just basically an acute tear that's been going on for a period of time. And those can still do well. So these meniscal tears are often associated with ligamentous injury as well. So think about that ACL injury. You have a patient that looks like they have meniscus pathology, but also ligamentous injury, and there's a chance you need to send them back to the doctor, particularly if this patient wants to get back to cutting sports. You're probably going to have more positive outcomes with patients getting ACL reconstruction versus not. All right. So who is going to be a good candidate for surgery in degenerative tears? So basically folks that fail conservative management and continue to have symptoms, so pain or disability, for a large period of time after their onset of symptoms. Based on the ESCA guidelines, you want to wait at least 3 months after the start of rehab to consider surgery. And this is based on not only those ESCA guidelines, but the European consensus on the treatment of meniscus pathologies. The other where we may consider surgery right away, and this is may, because we don't have research to see if these get better over the course of time, is an objectively locked knee. This is based on a weak recommendation from the ESCA guidelines. What I will say, this is a complete anecdote, but I had a patient relatively recently where she came in with an objectively locked knee. We were able to unlock her knee, right? So I just did a whole bunch of different distraction, joint mobilizations, wiggle that joint around. And eventually it kind of dislodged. And she eventually ended up getting surgery for meniscus repair because it was a type of meniscus tear that she could get repaired. So I think that was the right way to go. But do keep in mind that these objectively locked knees will sometimes unlock. And now all of a sudden, they're not an objectively locked knee. And if this was more of a degenerative issue, then maybe we do treat these conservatively. So I think the takeaway here is that objectively locked knees probably need to be treated differently, but sometimes they unlock, right? Yeah. You ever seen that happen before, Kevin?
Yeah, you had the key to unlock the knee.
Oh, yeah. I took the key out of my back pocket and boom. And to wrap things up here, this is going to be taken from an article. So Sona Karkas, 2024, and JOSPT basically said for non-traumatic degenerative meniscal pathology, conservative treatment utilizing a physical therapist intervention approach should be prioritized as a first choice over surgical treatment. It offers comparable or superior short-term pain reduction and strength improvements with a lower risk of side effects. You agree with that statement, Kevin?
I think that's beautifully said.
All right. So now you're an expert when trying to figure out if your patient needs surgery or should do physical therapy, but you still might not have a good background on the meniscus. Well, we can fix this. Above Kevin's head, right there in the corner, we have a video for you. It's what physical therapists need to know about the meniscus. Go ahead and click on that, and I'll see it in that video. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain-Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.